So let's move on to the next system, which
we're
is GI.
working our way down.
Yeah, now we're down into the belly, so we're midway through.
Yeah, a lot of things that can cause
It's
fever
a lot
in
of
the belly.
things.
Yeah.
So let's talk about the belly, and there's a lot in the belly that can cause
There's
fever.
so
We
much.
are very familiar with a lot of these. This is one of those general slides that sort of reminds you that there's left upper quadrant, there's right upper quadrant, all the different things that could be in those different areas. Some of these things are going to get CT scans, some of them are going to get surgical consultations, but then you also have patients who have non-focal abdominal pain, diffuse abdominal pain, and that could be things like peritonitis, which actually has a list of things that cause peritonitis. So the differential is quite large, and you've got to get your exam, you've got to get your history to kind of nail it down as to what's going on. So there's a huge range. Some of these things we see way more commonly than other things, but some examples of things to keep in mind. Don't forget about peritonitis, which we'll talk more about. Intra-abdominal abscesses. Don't forget about that biliary tree. Appendicitis for sure, which can be tricky. And that's why we talk about appendicitis so much, because it can be tricky. It's not always just right lower quadrant pain. We've got colitis, both infectious colitis and also inflammatory colitis, diverticulitis, of course, and then our invasive diarrhea stories.
That's a lot.
It's a lot. That's a lot. Let's talk a little about peritonitis. So we're very familiar with spontaneous bacterial peritonitis, or SBP. We see this in patients with cirrhosis who come in with their ascites that we tap, and we're looking for this infection. Sometimes they have pain or just a little bit of pain, but they can also look really, really sick. So we have a very low threshold to tap because we know that that clinical picture can be misleading.
Right. They can look really benign and have an infection in there. So
that's right. But certainly someone who has ascites and has belly pain, they need to have a tap. You have to go looking for this. You have to go looking for that SBP. And what do we send that fluid for? We send it for cell count and that differential, gram stain and culture. Also, sometimes we send it for glucose and protein and albumin and LDH. There's a lot of things you can send, but certainly the cell count is something that we all depend on to sort of rule this in or out. And what is that positive number you're looking for? It's 250 cells, white cells in the fluid. So it's the PMNs that you see. It's 250 is your cutoff. And if you see that, you're going to get on board as quick as possible, your IV cephalosporin or a fluoroquinolone. But that third generation cephalosporin is generally where we go. Now, in terms of acute bacterial peritonitis, this is kind of thinking back to how we learned about it, because we think about SBP all the time. But actually, there's primary peritonitis. There's also secondary peritonitis, which happens once you perf something after some kind of a trauma or an operation, et cetera. And then you have tertiary peritonitis, which is you had peritonitis, and then it still is going on 48 hours later, you still have peritonitis again, like it basically came back. And these are the different categories. In terms of peritonitis, don't forget, there's not just ascites and SBP, but there's also people who have peritoneal dialysis catheters.
Right.
And it could be from your fallopian tubes. It could be from your VP shunt.
Anything that's in there.
Anything that's in there can give you peritonitis. The pathogens depends on what's causing the peritonitis. Someone who has a peritoneal dialysis catheter is going to have some different etiologies than the person who has cirrhosis. So Pseudomonas comes on that list when you're talking about plastic or some kind of device.
Yeah, right.
And then if you're talking about secondary peritonitis and you're talking about biliary tract or the liver, et cetera, you have to think about those different etiologies that can go with them. So depending on your etiology, cover for different organisms. And this is what gets at that. Which antibiotics would I pick? Well, if we're talking about community-acquired things versus someone who's really, really sick or someone who's been in the hospital recently, that can affect which drug you're going to pick. And this chart kind of walks you through those kind of more unusual scenarios, but what you want to think of in terms of broadening your coverage as you go along from not as sick to sicker.
Right. So as we go down into the belly, let's go down to that right lower quadrant. So appendicitis is something we see all the time. All the time. And the reason that it's not a slam dunk super easy is that all the things they taught you in school were a lie. Well, not all, but a lot of them. Like, it is perfectly reasonable and perfectly acceptable. We've all seen the person who's chowing down on the Big Mac and fries, complaining of right lower quadrant pain, and hasn't had any vomiting, and they have a raging appendicitis. So the things that they teach you as dictum, it starts at the periumbilical, starts epigastric, periumbilical, right lower quadrant. No, it doesn't. It does that a third of the time if you're lucky. So the reality is anorexia can be present, but it doesn't have to be. Fever can be present, but it doesn't have to be. What is helpful is that it's tender down at McBurney's point. You go down there, you poke on it. That Big Mac attacking guy, you're poking on his right lower quadrant. If he has tenderness there, that is it. Okay, they may have rigidity, that's fine. They may get the migration pain, but the reality is that really helps you the most. If you want one thing that's in a history and exam, that's the thing that's going to help you the most. And the thing that we worry a lot about with appendicitis, because we tend to it's just more indolent in its presentation, is perforation. And we see that in the elderly and small babies, small kids, where they really can't can't tell you what's wrong, or they're vomiting, but yeah, kids always vomit. Today's vomiting is from their appendicitis. And the elderly just tend to perforate early for a lot of reasons that are related to aging. Your white count, which is our ongoing battle with the people who need to do the right thing, the white count can be anywhere. The white count can be normal. There was even a period of time where with 2 white counts, where I will get the second one and see where it's going. It's like, again, we don't respect the CBC anymore. No. I really don't respect the white count anymore. No. It doesn't necessarily help you here. It can be completely normal.
We've all seen appendicitis with normal white counts. Oh my gosh,
crazy,
so many
crazy,
times.
all the time. And if someone's pregnant, now appendicitis is the most common surgical, not GYN, OB/GYN, but surgical emergency in pregnancy. The appendix can, it doesn't always, but it can, as that gigantic uterus gets up to here, move the appendix kind of out of the way. It tends to move it up and toward a little bit the midline, and actually can move it more toward the back as it shoves it kind of out of the way. So they can end up with the symptoms being not where we expected at all if they're pregnant, especially advanced pregnancy. And imaging for that sometimes is MR, because we don't really want them to get radiated with a CT scan. Now, we also don't really want kids to get radiated with a CT scan, and to be frank, I don't really want anybody to get radiated with a CT scan if I don't have to. So ultrasound is definitely the first test in kids, and most kids have not enough tissue to get in the way. They can see the appendix on ultrasound. Ultrasound first is the way to go, and often will give you the answer. And adults are the same. My stepdaughter had appendicitis. We told her as a young healthy woman to go to the hospital and say, my parents said, don't get me a CT scan. I want an ultrasound, because the ultrasound made the diagnosis. It's actually quite good. CT, of course, is what is the kind of gold standard here. Yeah. And it is something you're going to have to do if you're thinking about antibiotics only, which we'll talk about in a second. But the reality is ultrasound is fine, MR for pregnancy, and CT scan for if you have any question. If somebody has a low-lying appendix, they may present with rectal pain or rectal urgency, where they feel like a pressure down there. Sometimes that is how they present. We tend to see that with other things more commonly, though. And you can, when you do a pelvic exam, have cervical motion tenderness in appendicitis if it's down there kind of poking around. It can make it a little difficult, but to be frank, PID is usually much clearer. And if you have any question, you're going to go on to image. The thing that is not fair, this is one of those things on my list of talking to the powers that be if I ever get a chance to talk to them, is the fact that you can have pyuria with appendicitis. If that inflamed appendix is tickling your ureter, you can actually have pyuria, which is kind of a drag. That we always check a urine, but if it's appendicitis, it sounds like it smells like it. Bernie's point, it's appendicitis. They just happen to have white cells in their urine. And I mentioned that this is the most common non-OB surgical emergency. The reason it's so important for us to diagnose it and diagnose it accurately is if they rupture in particular, preterm labor, fetal death is definitely on the list of things. So really think about the possibility of appendicitis and abdominal pain in a pregnant woman, especially the more pregnant she gets, because it tends to get a little more confusing. The treatment for appendicitis may vary. Now, surgery still is the gold standard, and there's been we're all aware, and there's been enough time, I think, with this being at least out in the literature, for the concept of antibiotics only to be brought up, even on an exam. I think most of us still default to surgery unless it's a high-risk person, and this sort of shared decision-making thing can happen about here are our options for treating you. Surgery still is sort of the bottom line. I'm not sure if ABEM General will go here.
I don't know if they will. I doubt it. But certainly if it is mentioned, you would never make that decision by yourself.
Exactly.
The safe thing to do would be the surgeon can make that decision or make the decision with you, but you would never go out on a limb and do it on your own. That definitely is not safe.
Agree. Absolutely. Now let's go to the sort of other side. Let's go to diverticular disease. And it is the other side, the left lower quadrant in the Western world. What is interesting is that the Japanese in particular have right-sided diverticular disease more commonly than the non-Japanese population. So if you have in fact, I suspect if you work somewhere where you have a lot of Japanese patients, you may have seen right-sided diverticular disease where they come in looking like an appy and whoa, it's diverticular disease. What's up with that? We tend to think about it in the left lower quadrant in the United States. And this is basically just the increased pressure in your colon, usually the sigmoid, scooches out these little balloons through the muscular layer of your large bowel. And there are risk factors for this. I'll tell you the biggest risk factor is we just eat a terrible diet. We just eat this. It's just a terrible diet, right? We don't eat enough fiber. We go through Big Mac and through drive-thrus, and we don't eat a great diet. It's basically low fiber diets really increase the risk of diverticular disease. And being older does. There's more time for things to meander through your GI tract. It tends to be more common in women before the age of 65, but then a little bit more and honestly, care about gender. If it sounds like diverticulitis, I don't care if you're a male or a female. It makes no difference.
We've all seen it in young people.
Oh
now.
yeah, and I'll tell you more and more. And that's
Yeah.
actually something that's enough of a trend that if it's a 35-year-old that sounds like diverticular disease, it's diverticular disease.
Yeah.
Obesity is a risk factor for this as well. People who are couch potatoes are a risk factor for this. So these are the risk factors for diverticular disease, and we kind of know that. If somebody has true diverticulitis, it's uncomplicated. That person gets broad spectrum antibiotics, and they can theoretically be treated as an outpatient. I think that's another one though at ABEM General. It would be a discussion with the surgeon. It would not be something that we would just say, "Oh, be gone with you."
Yeah.
If you have a CT scan, which is what we often do in diverticular disease to see what's going on in there, if it doesn't show any complications, any super, pockets of infection or phlegmons or large abscesses, we would give antibiotics. I think most of us would keep them around.
Yeah, I think they'd have to look pristine in terms of their, exam and their PO tolerance and have no comorbidities, and they have to probably have follow-up mentioned as well.
Exactly.
So it has to be all that stuff
talking
together.
to someone who's going to be doing that follow-up with super good come back for kind of stuff in your discharge. Now, operative and even in the hospital, most people don't end up in the OR, but they can. So abscesses goes to the OR. They're obviously perforated, so they're peritoneal. They go to the operating room. Those people need to go to the OR. So that's sort of the diverticular disease. That's the spectrum, and most of us are pretty familiar with all of that.
Yeah.
Another thing that we're probably more familiar with than we really want to be is C. diff. And C. diff, I have seen horrendous deaths from C. diff. I don't know, I just have a black cloud when it comes to C. diff. This is something that we see, we know it in the neonatal group, especially the preemie group. Antibiotics are the big offender here, although they don't have to have antibiotics, and that's the scary thing about this. So up to 30 to 40% of cases,
no antibiotics.
we don't know why they got it. It's if they have a trigger, antibiotics, it's 7 to 10 days after, but they can just come in with diarrhea.
Yeah.
And I'll tell you, the diarrhea it's cholera-like.
It's yucky.
It's profuse. It smells terrible. You kind of can tell if somebody has C. diff because there's just that odor in the ER, and they look really, really sick. They get dehydrated because they often just can't get out of the bathroom. These poor people. You test for an immunoassay in the stool. That's how we test for this thing. And if someone were to look, it would look like that. Our job, though, is to resuscitate. And the treatment, if we diagnose this, or even honestly, if they're super sick and you suspect it highly, is oral Vanco.
Yeah.
It's IV, the IV stuff, the liquid stuff is fine, but oral Vanco. It used to be metronidazole.
Yeah, that's right. This
Not
is an
anymore.
update. This is something that's changed. If you haven't reviewed this in a while, you think about metronidazole, but that's really now not the first line. It's the oral Vanco.
Oral Vanco. And again, nothing to make them worse, but this is scary, really scary stuff. And it can be recalcitrant. This can be something that just is stubborn and hard to treat.
Won't go away.
Right. Terrible, terrible stuff. Now, Jan mentioned that when it comes to the bowels, you have inflammatory or invasive causes of diarrhea, and they are legion. So we're going to go through a list of them, and the keys here that are in red are the kinds of things that will be in your question, in your sort of stem of your question, or in some of the possible answers to your question. These are the things that you need to be aware of as causing things of invasive or inflammatory diarrheas, and one of them is enterohemorrhagic E. coli, which is the 0157H7. So basically, it's enterohemorrhagic E. coli, and enterohemorrhagic causes gross bloody stools. So this is somebody who has bloody bowel movements. And the sort of the classic undercooked burger you got at that drive-through can give you this. But also petting zoos, raw milk, and untreated water can do this. So this is not the traveler's diarrhea. That doesn't give you fever, by the way. So that's why it's not in here. This makes you sick. Okay, this makes you sick. This is associated with TTP in older people and HUS, hemolytic uremic syndrome, in younger people. And because antibiotics can increase the risks of those, particularly HUS, antibiotic treatment is a debatable thing. I tell you, it's hard not to treat somebody who has this. They look terrible. They feel sick. They can have pretty high fevers. So this is something that I think most of us will treat. And I get the idea that it may increase the risk of HUS, but this is why we get consultants involved and specialists involved, because this one's a hard one to avoid giving antibiotics to. Shigella and Salmonella. Now, Shigella, the place where Shigella gets asked in ABEM General is the little kid with diarrhea who has diarrhea, and you're all worried about diarrhea, but they're a little bit altered, and then they seize. Mm-hmm. Well, what could that be? There's your stem of your question. 2-year-old diarrhea, seizure, boom, Shigella. So there's a toxin, basically a neurotoxin that's part of Shigella. They get febrile, maybe febrile seizures or toxic seizure actually, and they may precede the diarrhea. They may just come in with the fever, seize, and then Rick Buchanan tells a great story of what during the tap, the diarrhea appears, and there you go, you have your answer. The thing about Shigella, it's treatable. Cipro or Zithro work great, but it is unbelievably infectious. Theoretically, 10 organisms can make you sick with Shigella. It's one of the things that if it's an adult with this, you're going to ask them what kind of business they're in. Because if they work in a nursing home or if they work in a restaurant, you're not going to want them to go back to work until they've been basically tested for cure. Another one we think about is salmonella, right? Salmonella is also very common. And this is watery or mucoid kinds of stools. This is the pet turtle, right? This is the little kid that kisses their pet turtle that they get for their birthday. Eggs and chickens do it too. Salmonella is kind of everywhere. I was on a trip to Peru where all of us got salmonella because we ate an egg dish that was a little bit undercooked. We had a group of, 18 of us with salmonella. It was really not pretty. We were in the middle of nowhere in Peru. So it's bad. And we know can cause osteo, particularly in sickle cell patients. And that's another testable thing that comes up all the time is osteo in a sickle cell patient. And again, treatable, ciprofloxacin is what's recommended for here. Now, if you wanted to go where the money is, if you're going to go to Vegas, and you're going to say, I want to put my money on infectious diarrhea, which one's it going to be? It's going to be Campylobacter. It's the most common cause of bacterial diarrhea. It's called backpacker's diarrhea. It's contaminated food and water. There's a carniceria across the street from our hospital that basically wiped out like half of the nursing staff when they bought food that had this in it. It's be careful of the little taco truck and make sure it has an A on it so you get the right thing. This is fecal-oral spread. It's a short incubation. So you had your tacos on Monday, you're sick on Wednesday. And you are sick. It looks like inflammatory bowel disease. You're febrile, you have belly pain, you have bloody diarrhea. It may look like appendicitis. It looks terrible. Again, very treatable. Erythromycin works great, by the way, for this. For quinolones, again, I'd like to not use those, so you can for this. Erythromycin's fine, though. And it is associated with Guillain-Barré. Again, associated means what? It means there are a couple of cases that we saw in these people. It doesn't mean you're going to get it if you get Campylobacter, but it is associated. Now, the Vibrios are a little bit different. So Vibrio perihemolyticus, this is raw oysters, clams, and shrimp. And this basically it's a short incubation, basically. It's a relatively short incubation syndrome, but it's not the one that I worry the most about. The one that I worry most about is vulnificans.
Yeah, for sure.
And the thing so you think about this as an invasive diarrhea, except that if you have liver disease and you get vulnificus, you can end up with a aggressive, disastrous necrotizing fasciitis that basically kills you quick.
It kind of get through the liver cells and just sort of get out into the bloodstream, and then it settles in your
it's weird places. Like I got a patch on my side and a patch on my thigh, and this can be pretty devastating. So this is actually testable in that they're going to give you a person with liver disease and who's been at the shoreline in brackish water, getting oysters or eating oysters, and then they come in with what looks like a skin problem. You're going to need to know that that's a Vibrio. Yersinia enterocolitica is testable because it looks like appendicitis. So this is undercooked pork. This is where we tend to get Yersinia enterocolitica. It's an invasive gram-negative bacteria, and it causes colicky belly pain, and it can come in looking like appendicitis. They're tender there, all the things, right? I push down there, it's tender. Oh my gosh, that's what they told me when I did my EMCert Module Mastery, that's appendicitis. Well, no, it actually may be invasive, invasive diarrhea, Yersinia. This is diagnosed by fecal testing. By the way, when it comes to diarrhea, the IDSA does not recommend sending fecal white cells, mainly because it's not specific to invasive diarrhea. It may be with inflammatory kind of diarrheas as well. They don't really recommend sending testing, but sending cultures is a good idea. O&P stuff is only for prolonged symptoms. So as far as sending tests for this one, they're going to recommend that you actually do send a stool culture. And maybe if you're really worried about it, you can do a right stain. Good luck. Call your lab. Yeah. Do a right stain. Say, what? But you can consider doing a right stain. And this is basically supportive treatment, quinolones or trimethoprim sulfa, if they're complicated. Otherwise, you don't even treat this. This tends to go away by itself. So if you're a tables person, we have a bunch. So we have some tables on selected diarrheal disorders, and it basically goes through the symptoms across the top of here, and particularly which ones cause bloody stool, which I think is particularly helpful, and which ones cause fever. You can go through this and kind of look at the list. I'm not going to drag you through it. This is meant for your sort of reference. It's kind of handy even in real life if you can't figure out which is which. It's a nice way to kind of put this all together. And it has some parasites in here too, which we will talk a little bit about in a second. This is another one that basically has selected infections specifically. So if you happen to be clairvoyant and you know what the infection actually is, you can start there and work your way across. So these two tables are basically similar information kind of flipped on how they're actually listed. Let's talk about the gallbladder. So gallbladder, but I'll tell you, Anybody who works in an emergency department.
We're very familiar with this.
We become gallbladder experts. And if you ever want to get certified in gallbladder ultrasound, just come to the ER for a shift or two, and you'll do your required 20 or 30 or 40 ultrasounds because we see so much gallbladder disease. Stones are really common, right? They're really common. Usually cholesterol stones, bilirubin stones are what we see in people that have, or uric acid too, but bilirubin stones happen as well. Uric acid stones can happen that's kidney. Bilirubin and cholesterol stones in the gallbladder. They get colicky pain. The stone gets stuck and they get nausea and vomiting. Now that's just cholelithiasis that's symptomatic, right? That's not cholecystitis. Cystitis is when it obstructs something. Nausea, inflammation, they end up with increased white cells, they get a true infection, usually E. coli, sometimes Klebs. And there are a lot of things that work for this. And there are different kind of concoctions, your institution. The big key here is to cover those organisms, to cover E. coli and Klebs. And gallstone ileus is kind of cool. I've only seen a couple cases of this, but it's so cool.
Yeah.
It's so cool. This is usually a gallstone the size of your head. It's usually a big gallstone it's not a bunch of little guys. It's usually a big one that kind of hangs out in that gallbladder and then eventually erodes through into the small bowel, meanders its way down, and then gets jammed at the ileocecal valve. So they come in with what may have sounded like gallbladder stuff, and then that's kind of better. And now they have evidence of obstruction, of ileus. They basically have an obstruction. It's so cool.
Yeah.
Yeah, we have a CT scan that shows, and what you'll see is air in the biliary tree. It is awesome. So you go up to that right upper quadrant. You can see it on a plain film sometimes, that biliary tree full of air. I love the picture here on the left. Look at that beautiful biliary tree. And then, of course, on the CT scan, it's like, oh, duh. There it is. Yeah. I see all of that. And sometimes on that CT scan, they'll go down and they'll say, oh, check it out. There's a stone down there at the ileocecal valve. That's gallstone ileus. That actually is rock star material. It's really fun. Now, your gallbladder can get inflamed without stones in there, though. So acalculous cholecystitis, it's about 10%-ish max, but you see this with other things. So this is the person who's in the ICU. This is postpartum. This is a trauma patient. Post-op opioid sepsis can cause this, where basically the gallbladder wall is thickened. They actually look like they have cystitis, which cholecystitis, they do. They just don't have a stone in there that's causing this. And this can be pretty devastating. We see it in diabetics and the elderly more, and there's a lot more morbidity than with calculous cholecystitis. And the thing that we really all worry about is that an infection in that gallbladder deciding to go north. If it decides to climb up the biliary tree, they get, especially if they're obstructed, they get ascending cholangitis, and they can get so sick. Now, this triad, any of these triads, like Beck's triad and Charcot's, all these triads, we don't ever get the triad. Yeah. We get like one or two.
You read about the triad.
You read about it.
You know the triad.
Yeah, but it just, in real life, it doesn't seem to pan out. What we get in real life with ascending cholangitis is fever and right upper quadrant pain and maybe looking really sick. Yeah. The jaundice, it doesn't happen as often as it would be lovely, but it just doesn't happen as often. So you just worry in that sick-looking person who has either acalculous or calculous cholecystitis. And for all the cystitis, ultrasound is the way to go.
And I think that the jaundice happens over time. You know, we see them early in their course, and the bili hasn't gotten to that high level yet. That's something a surgeon describes that because they see them in the ICU and they follow them over time, but we don't always see it yet. So,
exactly. Yeah. Or they come down and say, "How could you miss this? Like, can't you see how yellow the patient is?" It's like, but they weren't before. Yeah. So ultrasound is magic. So cool. Yeah. It's so fun. It's so fun, right? I just love this. This is my favorite ultrasound, except for the OB ones that are good. I love the OB ones that are good. But this is really fun. You see the thickened wall. You look for pericholocystic fluid. You poke on it with the probe and see if they have a sonographic Murphy's. It's pretty neat. It's pretty neat. So these images right now don't show inflammation. They don't show any of those scary things. So if they gave you pictures like this on an exam, you're going to see the stones. That's all that shadowy stuff. But you don't see pericholocystic fluid or a super thick wall or anything else that would tell you that this person has a lot of cholecystitis. And this is a table just for you to have for reference. That is this is another one of those brilliant ones. They put everything in there, everything that could happen to the biliary tree. Love this. Yeah. So here's a nice kind of summary as far as the symptoms and things are concerned. So we've meandered through the gastrointestinal tract.
We have.